Optimism in Action is produced in collaboration with KAZU, your NPR station for the Monterey Bay area of California. You'll find this episode and archived episodes at kazu.org/sidebar.
So it really goes deeper than just the physical care. And so it's spiritual, it's emotional. I've been here 10 years. So before coming to hospice, I had this naive idea that it was all about the patient. And indeed, it's not. For those of you who've experienced it, we really do an awful lot to care for the family as well.
That's today's guest on Sidebar, Monica Ojcius, Director of Strategic Development for Community Hospice and Health Services in the Central Valley.
Sidebar is brought to you by Monterey College of Law, San Luis Obispo College of Law, Kern County College of Law, and Empire College of Law, located in Santa Rosa.
Welcome to Sidebar, featuring conversations about optimism in action with lawyers and leaders inspiring change. And now your co-hosts, Jackie Gardina and Mitch Winnick.
Jackie, we have a wonderful opportunity today to learn more about something we've not talked about before on our podcast, and that is hospice care. And we're going to learn it's not just hospice care, but it's hospice care and a number of very critical and important related services. We have with us today Monica Ojcius, who's with Community Hospice and Health Services. My family has had the benefit of using hospice, first with my mom and now with my dad, and our producer Dave Eakin has as well. And we are one of many who will do nothing but sing the praises of hospice in both its service to the individual client and the entire family. So I'm very excited to be able to talk about these services and help people better understand.
I'm excited to hear more about it too. While my family hasn't used hospice, I have several people in my life who are involved in hospice care with their medical work. So very excited to give a shout out to them and to the work that they do, which I know is very challenging. And Monica, welcome to Sidebar.
Thank you so much. I'm excited to be here today.
Monica, let's start a little bit with a description of hospice. I think to the extent that people are familiar with the term, they think of it in a very, very narrow manner. They think of it as an individual or a nursing or healthcare that comes in at the very end of life to help an individual and their family go through the final stages of death. But that is not where hospice is in this day and age, is it?
I think you're right that is a general perception in our society, that you wait until somebody is literally, quote unquote, on their deathbed, and then you call hospice. What I would suggest is, we've kind of grown up. Our specific backstory is we were founded by two nurses who happened to be married to oncologists, and their husbands were coming home and saying, there's just not enough to do for my cancer patients. They're living in pain, they're dying, and their quality of life is diminished. There's got to be more. These two nurses were doing their master's thesis and said, you know what? We heard about this thing that started on the East Coast, and it's called hospice. It's about creating quality of life. And Congress drew a line in the sand and said, okay, if somebody's doctor says we think you're going to live 6 months or less, you qualify to receive hospice services. But the vast majority of people wait until it's 3 days or 3 weeks to really be able to get the word out that there's help available further upstream, I think is a really important message for us to send out.
Mike, I want to talk a little bit about what you started to talk about, which is the origins of your organization, the Community Hospice and Health Services, because it started in what I think is a really wonderful way. And what I want our listeners to know is that there is an opportunity for anyone who wants to make a change in the world to start this.
So they brought this concept and told their husbands about it. The husband said, that sounds great. Let's see what we can do to build something like that here in the Central Valley of California. The very first staff, if you will, were all volunteers. The medical director was a volunteer. He had his own practice, an oncology practice. We relied on local hospitals and medical supply companies to kind of offer us whatever they had left over and didn't need, and they could donate to us. That's how we got started. So we were an all-volunteer hospice, which There are some nonprofit hospices in California today that are all volunteers. Later, we became certified through Medi-Cal and Medicare CMS. And so we are a fully certified and accredited hospice today.
And one of the important things you just said was this idea of funding through Medicare or Medi-Cal. That means that if an individual qualifies, aren't they fully paid for through their Medicare and Medi-Cal payments?
Absolutely. The exception to that would be if they need an inpatient unit. Our organization 20 years ago developed our Alexander Cohen Hospice House. And so it's the largest inpatient unit of its kind in the state of California. We boast 16 beds. And Harold Peterson was our CEO at the time. Well, he watched his grandfather die and he watched his mother pass away, really without being able to have bedside access in the hospital, and to also watch them die surrounded by medical personnel versus family members and friends. And so this concept of having a hospice house where people, if their loved ones didn't want them to die at home or in the hospital, they could come and for their last several days or weeks of life, they could be in this beautiful, peaceful setting where family could come. There's not set visitation hours. They can come and go. Children are welcome. Each one of our rooms opens onto a personal patio. So if they want to roll their hospital bed out into nature and hear the birds sing and feel the sunshine on their skin, they get to do that. And so that was another innovation that our hospice brought to the Central Valley of California.
While you talked about that one house that you've built, is it my understanding that you guys have also created a pediatric hospice program as well? I had never heard of that before.
People have an assumption that it's just elderly people. By far, that is our population, people who are older, but it is surprising. And in 1998 is when we started to begin to formalize a pediatric hospice program. And we started off maybe with 2 or 3 children a year that would come onto our services. Their families would seek us out for some reason. They were just at their wits' end. It's tragic when anybody dies in your family, but when you have a child that is born sick and with a terminal illness, or if they get childhood cancer, and then, your 5-year-old is walking around and you're not going to, have them with you very long. It's very, very difficult for families. Our nurse angels said, we're going to take this on. So for a child, it's different. If you're an adult, you have to have that 6-month or less diagnosis. But for a child, something that our legislators did that I have to give them props for years ago is typically when you join a hospice or enroll on their services, you're forfeiting your ability to seek curative care. And so they want you to be comfortable. They want you to have quality of life, but it becomes about those choices, not how much longer can you stay alive based on medications or chemotherapy, et cetera. And those same rules used to apply for pediatrics. Well, about 12, 15 years ago, that has changed. And so now children are offered what's called concurrent care, which means their families and their parents can continue to go to the oncologist and the nephrologist to seek something that could extend their life and or keep them, maybe even find a cure. Our role in that is to take care of the palliative side, which is keeping them comfortable, training the parents how to be the best bedside nurse for their children that they can be, and then also offering respite. That pediatric suite that we added to our Alexander Cohen Hospice House is really for that. You've got 3 or 4 kids in the family. Mom's trying to get Joey off to soccer practice. Dad's taking Giselle to ballet. And then you've got our sick child. The family's just really stretched thin. Our hospice house now boasts a family suite. In it is a patient room. It's very whimsical. And then for the parents, there's an adjoining room that has a slide door in between it. They can go and have 24/7 eyes on their child as they want, or as they start to build rapport with our nurses and our doctors, and they understand, okay, community hospice is going to take as good a care of my child as I can at home. I might be able to go nap or watch a movie. As of today, there are 37 children, babies, and youth on our pediatric services. And we're actually gearing up for our 3rd annual Walk and Roll. It's a fundraising event and folks get to come. I think last year we had 350 people that came out, and it's a 1K, 5K. You can walk, you can roll, you can stroll, you can be in a wheelchair, you can have a walker. And our patients get to be the first in line to go when the gun goes off. So we're just very thankful that our community is supporting these families who have such a burden on their shoulders at this time.
I think one of the things that really came through in what you were just talking about is that hospice care isn't simply about the person who is experiencing the illness, but the entire family who is surrounding that person, and you care for both through this process. To help me understand kind of hospice care versus palliative care versus curative care, and what it is that is encompassed in the work you do.
Hospice care is available for people who have a terminal illness. Nobody's got a crystal ball, but in the doctor's best guesstimate, you will live 6 months or less, that your life is going to be that short. Palliative care, it's been happening for a long time, but it's been formalized just in the last decade. We started our formal palliative program about 9 years ago, and that is for people who do have chronic illness, a serious illness. They might have a cancer, COPD, kidney disease, diabetes, something that eventually is going to be very serious. And so we want them to have support from our social workers and our nurses. So we have a community-based palliative program, which not all hospices do, just to distinguish that. We will go to people's homes or wherever they call home. We've gone to people's cars. We show up on park benches sometimes. We will go to wherever their residence is that they call home at the time. Our nurses will serve them. Our social workers will try to connect them to community services. And they are still able to seek curative care, which is what you asked for, that distinguishment. So if you're palliative, you get curative care. If you're a child on our pediatric program, you can seek curative care. But if you're an adult on hospice, that's probably one of the biggest decisions that families have to make. We'll have people that are hospice eligible and the families aren't ready. I want to take mom to the hospital one more time to see her specialist. Probably something else that the audience might be interested to know is if you sign up and you enroll in hospice and you decide a week or two later or a month later, that's not for you. Okay, we graduate you. You get to go off of hospice. When you're ready, you can come back. No harm, no foul. The other thing that I hear we call the myths is that if you go on hospice, you have to sign a DNR. And that's not true at all. A DNR is just something that you've signed on your advance directive that says do not resuscitate. So that's what those initials stand for. In hospitals, they'll put a band on your wrist and write DNR on it so that any medical personnel that come into the room understand if you've stopped breathing or if your pulse is gone, your choice has been made that you don't want to be resuscitated. And some people, for whatever reason, think that because you're on hospice, that applies across the board. No, family and the patient still have choices.
Each hospice is its own individual entity and sets its own scope, its own rules, its region. Although you have certain standards that are set, I presume, by Medicaid and Medi-Cal, that is it. Other than that, you have a fair amount of flexibility to select which services you provide and which region you serve.
We happen to be a standalone nonprofit hospice, but our industry is really changing. And so, we're 46 years old. And when we got started, the majority of hospices were not-for-profits. And now that has flipped. This might sound a little crass, but dying has kind of become big business because of the boomer generation. There are conglomerates that are now dipping their toe into the hospice industry pool. And so it's about only 20% are nonprofit now and the rest are for-profit. So our nonprofit has a 50-mile radius in which we can deliver hospice services. We do offer mental health services, which is kind of unique. And so those services go beyond those 50-mile borders. We can serve people wherever they want to be.
Honestly, I don't think I could tell you I know whether or not the two hospice organizations we use, one for my mom, one for my dad, or profit or nonprofit. It struck me that the services appear to be the same. Is there any other distinction other than their corporate structure?
So one of the requirements that we have, and it's not different than hospitals per se, is that if a person calls, we just see people as people and we're going to serve you whether you have insurance or not. And you're going to get the same excellent care whether you have insurance or not. But we have an obligation to provide charity care, like hospitals do, right? You don't turn anybody away. That's true for hospice. Our palliative program's a little different. We have not gotten a green light from CMS. So people with Medicare per se, unless they have an Advantage program, they don't qualify to get palliative services. It's Medicaid, Medi-Cal folks that qualify for that program.
Monica, just on that note, how are the potential healthcare funding cuts going to affect the work that you do and people's access to the work that you do?
The reality for us is if there are more people that are uninsured, which that kind of seems like that could be the trend that we're going to experience, then our foundation efforts and philanthropy, the caring of our neighbors for each other is going to be what is going to be required for us to keep the same level of access for people.
Support for Optimism in Action comes from the Monterey College of Law, a nonprofit law school serving the Monterey Bay region with evening classes on campus or in a hybrid online format. More details and applications available at montereylaw.edu. That's montereylaw.edu.
It's an extraordinary group of people who choose to do this type of work that I think many of us just shy away from. We shy away from it in our own family and in our own circumstances. And yet you have collected a group of volunteers and professionals who just quite the opposite, flock to provide these necessary services. Talk about that passion and that mission and what draws people to do this kind of work.
Thank you. I think that's really an essence. It's a calling. A lot of our nurses will talk about it as I got called to do this work. And it was so interesting because during orientation, I would always ask the question, what brought you to us? And they would say, I'm just so tired of death. And then I'd be like, we're a hospice organization. And yet it's the difference of people choose to come on hospice or they choose to be on palliative care. And so death is expected and you're no longer trying to prevent it. You're working for both the patient and the family to give them an experience that is rich with integrity and dignity, all the things that somebody deserves, and to celebrate that life. There's even a spiritual component to hospice care with our chaplains. Really, some of the magic is not what a traditional medical field is, which is to prolong life and cure people, but it's to help people transition. We see broken families come together. Our people are brokering. So it really goes deeper than just the physical care. And so it's spiritual, it's emotional. I've been here 10 years. So before coming to hospice, I had this naive idea that it was all about the patient. And indeed, it's not. For those of you who've experienced it, we really do an awful lot to care for the family as well.
And I can give you a first-hand referral on that. I don't even know the questions to ask. And yet I found that having access to a hospice nurse, even more than any doctor's assistance we had, these were individuals who had been down this path so many times. They knew what I was trying to ask. They understood what I needed to know, even at times that I didn't know what I was asking. And so as a family member, I found that just incredibly useful and helpful in planning what we needed to do as a family. So it's just that mentality of bringing that calmness and direct communication with the family that I don't find anywhere else in healthcare.
And given that, Monica, why do you think people avoid taking advantage of the kind of care they can get through an organization like yours?
Fear. I mean, I really think that fear rules that. I would even go so far as to say sometimes the opportunity to engage with a hospice organization, regardless of where you live, a lot of times that's predicated on the doctor who's caring for the patient. And so sometimes we have stumbling blocks even within the medical field. And granted, I don't think our doctors get the kind of training around end of life to best prepare them for those difficult conversations. And it is a huge transition when you go from like, we're going to try this and we're going to do this. And 2 months, we'll see where we're at and we'll test your blood and blah, blah, to we're done. If I were going to say to the audience something that could help them is to say, when you have a diagnosis that's terminal, when that happens, regardless of what it is, people don't think about hospice until they need it. And so go ahead, call your local hospice and ask for what's an EOB. Have somebody come out to the family, offer an explanation of benefits. There is no requirement that you make a decision at that time, but it will inform the family what your options are. What does the caregiver need to do? What does the hospice do? What are the options? And I really think that families would be better served if they had that information up front, not, Mitch, when the emergency happens, not when you're dialing 911 and your heart's racing. And we just, as humans, our frontal lobes don't process information very good when we're in a panic mode, when we're in that fight or flight. So when people can be calm and really take in information, that's when I would call.
Let me ask about something we always talk about on this program, which is how do volunteers and even philanthropic individuals get involved with hospice?
Love that question. We really rely on our volunteers, and I'll give you an example of that. Because we are a Medicare certified hospice, there's a requirement that 5% of all the service hours for patients have to be provided by volunteers. So that's like a tall standing edict. And so we're always looking for patients. And a lot of times we get that from folks who are survivors. They've had a loved one come through our services, and a year or two down the road, they're ready to give back. And so they're like, you know what, I could do this. I could sit by a bed. I could read to a child. I could go help in the office. I can stuff envelopes. I can make phone calls. We're always looking for veterans. Our staff are specifically trained on how to work with veterans. And there's nothing easier or harder, I guess, having a veteran sit by the bedside of another vet and just let them talk about what they did in their life. And sometimes they have stories they keep really close to the vest, and they don't even tell their wife about it or their children about it, but they can release that, whatever anxiety they might have or those memories, to another vet because they've walked in their shoes, and it just makes a tremendous difference. In terms of philanthropy, we have people that serve on our auxiliary group that raise funds for us. We have a foundation board. We are always looking for folks who have expertise in certain areas to come alongside and share that expertise. So there's really opportunities for everybody. And whether you can donate $5 a month or $5,000 a month, every penny counts, and it gets put to work right away.
We're calling this season Optimism in Action. And hospice isn't often associated with optimism. In fact, sometimes it's associated with the opposite. So when you think about the work that you do, what do you see as optimistic about it?
Where I think people find hope is that through the process, they know that they're getting the very best care for their loved one that can be provided. It also gives them time for reflection. So the sooner you get hospice into your house or your skilled nursing facility, wherever the patient is, the sooner you get added support. There's hope in that because caregivers, if you've been a caregiver, you know it is a tough job. But I'm keenly aware that the hope in hospice is really sharing that love. I call them angels, but it's really loving on humanity. Strangers are coming in your door in your house, and yet they are kind, have wisdom about this subject matter, walking people through what to expect. And especially if it's your first time, that's scary. That's dark area, but you can shed light for people and you can help them walk through it together so they're not alone. And so I think that's the hope in hospice.
Can you talk more about Community Hospice's health services and how that came about?
Something unique for us is we have journeyed into mental health services, and it's kind of this natural fit because we take care of people in bereavement. Generally speaking, for a year after a loved one is lost, we provide complimentary bereavement services, and that can be in groups, that can be individualized, but that's for any survivors that were on our service. We will provide that. Word got out some years ago that we do really good grief work. We had folks calling and just saying, my 17-year-old son just died in a car accident. I am beyond myself. I don't know how to function. Can you help me? Trying to be good community partners, we said, yes, come. we'll help. Well, pretty soon our community requests for support were outgrowing the number of hospice requests that we had. Out of the whole mental health piece of the pie, we were only covering grief. When you sit down with people, it's rare that somebody has only grief going on. We've developed something called Hope Counseling. We're really proud that we can now talk about, we offer whole person care.
You were talking about the grief counseling and the bereavement care and how you expanded that to the broader community and beyond just grief and really serving the whole person. How is it that someone would get access to those services? Do they need to be referred?
Actually, the Hope Counseling program is a mild to moderate mental health program. So people come and they see us for depression, anxiety, substance abuse issues, family relationship issues, kind of the whole spectrum. When I say mild to moderate, what that means is that we don't do medication management. I don't have a psychiatrist that's prescribing on staff, although we have referral sources that can get you to where you need to be. But one of the things that we have found just in interviewing and talking to people who have needs, number one, the stigma that is surrounding mental health issues is still alive and well today. And so what we find is people who work for companies, maybe they have a great EAP, an employee assistant program, where they could get a referral to go see a psychologist, but then usually their HR department knows they're seeking mental health services. And so we designed our program so that regardless of who's insuring you, there are programs, if you belong to a larger health that require referrals from a PCP to a specialist, we can bypass that. Mitch, if you fell and you broke your arm, you would go to the ER and you would get your arm fixed and nobody would blink an eye. They'd say, good job, Mitch, you went and got your problem taken care of. If you're in crisis for a mental health issue, or if you have an addiction and you're about to fall off that wagon again, you don't want to call your PCP, try to get an appointment that's going to take you 1, 2, 3 weeks, and then get referred to a specialist. It's going to take you another 2, 3 weeks, or sometimes I've heard months, because when you're in crisis and you need help then. So what we've tried to do is really work to lessen the time from when you make that initial call to when you can be seen and get help.
Monica, thank you very much for both the work that you do and the extraordinary work that you and all of the angels who work for community hospice and health services do in your community and in helping others understand that they should seek out hospice in the communities where they live. And as you mentioned, sooner versus later, because the first call may just be for information, and then they have a better understanding of what the pathway is going to be. It isn't a commitment. And in fact, people don't realize you could sign up a family for hospice, and then it turns out it was preliminary, and they can come back when necessary. So thank you so very much for what you do.
I'm so excited that you guys are doing a program like this. So thank you for having me as a guest.
Mitch, I wasn't sure about how we were going to talk about optimism and talk about hospice at the same time. As the conversation went on with Monica, and she talked about the families, and she talked about the healing, and she talked about the love, it became so obvious to me the kind of, I would say, hope that hospice gives to not just the individuals who are transitioning, but the people who love them. And it was just a joy to hear from her.
Jackie, I think you went right to the essential issue here, which is that a community doesn't die just because an individual dies. The family lives on, and the relationships within the family. And hospice really bridges that gap from the process of death to the ongoing part of life. And I would say that the optimism they bring into our community is that transition that takes individuals, not just the individual who's dying, but the family that surrounds them, into the transition to the future of their life and the future of their community. That is the circle of life that keeps communities healthy. And that, I think, is a very optimistic outcome.
Once again, I want to thank everyone who joined us today on Sidebar. And as always, Mitch and I would love to know what's on your mind. You can reach us at SideBarMedia.org.
Sidebar would not be possible without our producer David Eakin, who composes and plays all of the music you hear on Sidebar. Thank you also to Dina Dowsett, who creates and coordinates Sidebar's social media marketing.
Optimism in Action is produced in collaboration with KAZU, your NPR station for the Monterey Bay area of California. You'll find this episode and archived episodes at kazu.org/sidebar.